Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In previous videos, we've discussed the pathophysiology of type 1 and type 2 diabetes, but in this video, we'll dive into the treatment or the management of type 1 diabetes. And I think it's important to remember that in type 1 diabetes, this is the type of diabetes where we have an autoimmune condition that is eventually leading to the destruction of our pancreatic beta cells and subsequently an inability of your body to make insulin. And because the main problem here is that your body is not making insulin, your body doesn't have insulin, the mainstay of treatment for type 1 diabetes is simply going to be to add what the body lacks and give back insulin. A quick recap of how insulin works. Insulin binds to these tyrosine kinase receptors in its target cells, causing autophosphorylation of those tyrosine kinase receptors. This will stimulate several pathways, including the PIK3-AKT pathway, the RAS-MAPK pathway, both of which we talk about in our insulin physiology video. And the activation of these pathways will lead to several downstream effects, including the increase of GLUT4 channels being moved into the membrane. So this will allow more glucose to enter the cell. Increase glycogenesis. So we're going to take glucose and make it into glycogen for storage. Increase lipogenesis. So glucose gets turned into fats for storage. Decrease gluconeogenesis because we don't need to make any more glucose when we have it in abundance. And then increase cell growth and differentiation. Remember that this is an anabolic process, so we are making new tissues. Then insulin, when your body is making it endogenously, you will also release this C-peptide. However, when we administer exogenous insulin, because it wasn't made in the pancreas and we're not adding C-peptide to it because there's no real benefit there, when you administer exogenous insulin, you will not see an increase in C-peptide. This is a helpful fact to be aware of to understand whether someone's insulin level is going to be endogenous or exogenous. You can always measure the C-peptide, and that can be a helpful tool to use on step 1 questions. The largest risk associated with insulin is hypoglycemia. And a patient who is hypoglycemic may present similarly to a patient who has alcohol intoxication. So slurring of words, decreased level of consciousness, maybe stumbling and eventually passing out. But it's very important to identify if a patient is hypoglycemic rather than having alcohol intoxication, because hypoglycemia can actually be a life-threatening or fatal complication. It's a very feared complication of management with type 1 diabetes, which is why when we are administering insulin, which of course can make you hypoglycemic, we are going to attempt to use these very individualized, very tailored regimens of insulin to ensure that our patient has adequate glucose control, but at the same time does not get hypoglycemic. So a very fine line to walk there. The goal, as I just mentioned, of management of type 1 diabetes is going to be this strict glycemic control. So we want to keep their glucose within a tight range. Usually this range is 70 to 130. These guidelines, I think, were just updated for even tighter control, so I didn't put the exact numbers on the slide. I would doubt they would expect you to know that. However, the overall goal is tight glycemic control that can eventually prevent their complications, especially in these patients. So think about preventing diabetic retinopathy, preventing diabetic nephropathy. That is the goal of management in type 1 diabetes. In order to achieve this management, we use several different types of insulin, and the management of someone's insulin regimen can actually get quite complex and quite intricate. But at a very basic level, what we're essentially doing is we're giving someone baseline insulin. So you're going to have a long-lasting type of insulin that will provide you some baseline level of having insulin available in your body throughout the day and night. And then additionally, when you have a normal pancreas, it should be secreting more insulin in response to meals and snacks and more glucose available in your body. In an attempt for us to simulate what that would be like without you having a functional pancreas, we also give mealtime or snack time insulin. So this will be a shorter acting type of insulin that is intended to compensate for that rapid rise in glucose after you eat a meal or eat a snack. So we'll use these in complement. The baseline insulin provides you with that basic level of having some insulin available. And then mealtime insulin should be more quick acting, faster on and off to compensate for rapid rises in insulin associated with eating. The different types of insulin that we use to achieve this coverage are, number 1, rapid acting types of insulin. So their function is going to peak in 1 hour. You can see over here, they are the first peaking. And your fast acting types of insulin or your rapid acting types of insulin are Lispro, Aspart, and Glulucine. And this rapid acting insulin, that's usually going to be part of someone's mealtime or adjustable regimen. So because it's fast acting, its peak is around 2 hours. It's only really useful to adjust to those quick spikes in glucose, but it won't provide you with baseline control throughout the day. The next type of insulin that we'll talk about is short-acting insulin. Short-acting insulin has a 2 to 3 hour peak. It's just called regular insulin. So if you hear regular insulin, you should think of an insulin that is short-acting. And because it's relatively short-acting, as the name implies, regular insulin is also usually going to be used as part of that mealtime package, adjusting to quicker spikes in glucose associated with eating. Next, we have your intermediate insulin, and because it has a little bit longer effect, 4 to 10 hours, NPH can be considered more of one of these baseline insulins. It's often used in the hospital as a baseline insulin because even though it does have this 4 to 10 hour peak, if someone suddenly goes NPO or for some reason is no longer eating, you can discontinue it and you're not stuck with having insulin in this patient for over 24 hours and putting them at risk of hypoglycemia. So intermediate insulin or NPH is frequently used in the hospital and can be considered a type of baseline insulin because it does have a little bit longer peak of 4 to 10 hours. Then we get into our long-acting insulins. And these insulins are going to be strictly used for that baseline dosing of insulin. They are in the long-acting category. And the first one we'll talk about is glargine. Glargine has a steady release. It doesn't really peak, right? You can see that it's more of a steady release on this diagram. And it can remain active for up to 20 hours. So basically the whole day. And a lot of patients you'll see are on glargine because it is active for the whole day. So they can take it once and have some baseline level of insulin throughout the entire day, which is very convenient. And then our other option for long-acting insulin is detamir. And detamir is also long-acting. There's a little bit more of a peak. It takes about 16 hours. I haven't seen this one used as much, but certainly it is in circulation. And these are both long-acting insulins that will help you have some baseline level of insulin in your body for a long period of time. Now, I know that was a lot of information. Let's quickly recap what we talked about in this video. Type 1 diabetes is when you don't have any insulin in your body because of the destruction of pancreatic beta cells. You can no longer make insulin. Thus, the hallmark of treatment of type 1 diabetes is going to be the administration of insulin. We want to make sure that the insulin regimen is very tailored to the patient's needs to avoid the risk of hypoglycemia, but also have adequate insulin control so that we minimize their risk of microvascular complications. In order to achieve this, we use several different types of insulin. We usually pick a longer-acting baseline insulin, so either glargine, detamir, or NPH to give them some sort of basal level of insulin throughout the day. And then we will supplement with mealtime or more short-acting insulin, such as our rapid types of insulin, Lisipro, Aspart, short-acting insulin, regular insulin, to offset the rapid rises in glucose that accompany mealtimes. And then how they ask you about this on a board-style question? Well, something they might ask is a 13-year-old girl with known type 1 diabetes presents to her PCP for follow-up of elevated postprandial blood sugars. The patient regularly has postprandial readings in the 200s. The addition of which type of insulin to her mealtime regimen is most likely to achieve better glycemic control in this patient. Okay, so this patient has elevated postprandial glucoses in the 200s, certainly out of range. Postprandial means after you've eaten, so after she's eaten a meal, her glucose is spiking and we don't have adequate control. Which type of insulin is the most appropriate to fix this problem? Well, we don't want to give this patient a long-acting insulin or increase their long-acting insulin regimen because that is a great recipe to get hypoglycemia in someone who's just having these intermittent spikes. So they're only having intermittent high glucoses, but you increase their long-acting insulin, then when they're not having the spike in glucose, they're going to be pretty hypoglycemic, and that can be super dangerous for this patient. So definitely, we're not going to increase their long-acting insulin. We're not going to increase their NPH. What we are going to do is we're going to try to increase their mealtime insulin to account for these rapid rises in glucose and then quickly shut off and go back to our basal bolus. So we're either going to use a rapid or a regular insulin. So that would be Lisipro, Aspart, or regular insulin. And this is the answer that I would look for on step 1. Now, that's all I have for you on the management of type 1 diabetes. I hope this video was helpful, and I'll see you next time.